You've been looking at the COMBI-V study, a phase 3 study. You were trying two different approaches head-to-head on this. What were you doing? And this is for patients with melanoma.
So it's patients with melanoma, advanced melanoma, but also with a mutation of BRAF, which is about 40% of our patients with melanoma, somatic mutation of BRAF. We already knew that this patient can benefit from a treatment with BRAF inhibitor. This was shown some years ago, and now we are evaluating the combination of an anti-BRAF plus anti-MEK, namely Dabrafenib plus Trametinib versus single-agent anti-BRAF.
Right. Quick question, why didn't you go for Dabrafenib in both arms for the anti-RAF?
There is a study which is COMBI-D, where we have the combination versus Dabrafenib, but this one was versus vemurafenib.
And what did you get from this? It's now 2 years, isn't it?
So now we present the update of the result. You know, the study was stopped at the interim analysis because the results were so good. The overall survival was good at the first interim analysis, and it was not ethical to continue. We could cross over the patient and they could all receive the combination. And now we have the update, so we have an additional 11 months of follow-up, but for the patients it's 8 months of median follow-up. We can estimate the 2-year overall survival, so we know that after 2 years we have 51% of the patients in the combination arm who are alive versus 38% in the vemurafenib arm. And we have the two curves, on the Kaplan-Meier curves, we have the two curves really nicely separated. And the median overall survival in the combination arm is 25.6 months, which is actually the longest overall survival that we ever reached in a randomized trial in patients with metastatic melanoma.
Overall survival's looking good. What about progression-free survival?
It's also very good, very differently. Between the two arms, we have a little bit more than 1 year in PFS, median PFS in the combination arm, and 7-point-something months with the vemurafenib arm.
You're using a combination of two innovative approaches. Does this add toxicity?
Well, no, we already had this very good surprise, which in fact was not a surprise if you know exactly the mechanism of action. In fact, you have a combination that has more efficacy but less toxicity on some adverse events. Well, if you compare the absolute number of adverse events, it's very similar. The spectrum is slightly different. We have more chills and more fever with the combination because of the Dabrafenib effect, and we have all the adverse events that are linked to the paradoxical activation of the pathway, which are much more frequent with vemurafenib. But interestingly, with this update, we see that we don't had any other adverse events. With this additional follow-up, we have the same percentage of patients who have interrupted the treatment for a safety issue.
What are the clinical messages coming out of this for doctors then?
So it's very important. This is a very important result. This is actually the longest median overall survival in patients with advanced melanoma. So it's very important also to know that in the patients with low LDH, so which is the best population of patients, whatever treatment we do, it can be immunotherapy or targeted therapy, it's a good prognosis marker. We see that we have in this population of patients even a bigger benefit. So it's very important because right now everybody thinks about immunotherapy all the time, and these treatments is something that can be really compared to immunotherapy in this population of patients.
And these patients have the BRAF mutation. How important is that to the efficacy of this approach?
Well, you would never give a BRAF inhibitor to a patient who is not mutated for BRAF.
So now the message is clear. Is it clear between vemurafenib and Dabrafenib, though?
Well, it has not been tested head-to-head. Of course, it's never going to be done because it's not interesting now at the point where we are. It's quite equivalent. We have less paradoxical adverse events with Dabrafenib, but we have more fever and more chills, so it's not exactly the same, but in terms of efficacy, it's not very different.
So what brief message would you distill for doctors at this point to summarize?
Well, the combination of Dabrafenib and Trametinib is a treatment that should be a standard of care for patients with BRAF mutant metastatic melanoma.